Have you ever wondered how to interpret the urine dipstick results? This is George, and this is George's Solutions, a channel that speaks about medical content and day-to-day lives and also life hacks. Stay with me as we interpret to you the urine dipstick. So the urine dipstick is a narrow plastic which has several squares and different colors attached to it. Each small square represents a component of the test used to interpret urinalysis. The entire strip is always dipped inside urine, and the color changes in each square is always noted. The color change takes place within 2 minutes. That's so fast for dipping in the strip. And if you read the strip too early or too long after the strip has been dipped in the urine, the results may not be so much accurate. So some of the components that the urine dipstick measures include components such as the specific gravity. That is, generally specific gravity is just generally the concentration of the urine. Acidity of the urine, that is just the pH, whether alkaline or basic. Proteins in the urine, and the protein that the dipstick mainly measures is the albumin. Glucose, that is just sugar. Ketones, blood, bilirubin, urobilinogen, and nitrites and leucocytes esterase. So the main advantage of the urine dipstick is that it is convenient. It is very easy to interpret, like we are going to do that today. We are going to interpret it, and it is cost effective. And the main disadvantages of the urine dipstick include that the information that it contained in the test may not be very accurate, since the strip is very time sensitive. The more it stays, the more it reacts, or the lesser it stays, the lesser it reacts. So interpreting it too early or interpreting it too late might lead to false positive results. Another disadvantage is that it provides limited information about the urine, since it is a qualitative test and not a quantitative test. For example, it doesn't give you the precise measurements of the abnormality. It doesn't give you the very precise measurement of the abnormality. Yes, it can give you a range, but it is not very precise. It doesn't tell you that this is the exact abnormality. So in the place of instead of a urine dipstick, there have been automated urine analyzers that are based on the principle of flow cytometry. So these automated urine analyzers, the system classifies particles based on fluorescent intensity. Cells as stains with two fluorescent dyes, and the electrical impedance and forward angle light scatter is measured in this automated urine analyzers. Like the next generation image-based urinalysis system, that is the IQ200, it's a walkaway system, as this system uses a flow imaging analysis technology and auto-particle recognition software. It requires a minimum of 3 ml of urine and quantitates particles in 2 microliter of sample. It can also analyze 60 urine samples every hour. So the very first component that I want us to speak about in chemical analysis of urine is proteins in urine. So proteins in urine is a phenomenon that we refer to as proteinuria, and normally the kidneys excrete a scant amount of protein in urine, up to 150 milligrams in every 24 hours. And this amount that the kidney excrete actually cannot be detected in routine lab tests when we are doing urinalysis. The proteins that the urine that are excreted in urine include proteins from plasma, such as the albumin. Protein derives from the urinary tract. You know, the urinary tract, of course, has some protein in it, so these proteins can be excreted in urine. We have the term horsefall protein, secretory IgA, proteins from tubular epithelial cell, leucocytes, and other discriminated cells. All these are normal proteins that are excreted in urine. So proteinuria is defined as the phenomenon whereby the body excretes more than 150 milligrams in every 24 hours in adults. So the causes of proteinuria may include glomerular proteinuria due to the increased permeability of the glomerular capillary wall, such as during when you have a condition referred to as nephrotic syndrome. So when you have nephrotic syndrome, the glomerular capillary wall will be increased, the permeability will be increased, and this will pass some amounts of proteins, and this will be detected in urine. We have tubular proteinuria due to excretion of low molecular weight proteins which are actively reabsorbed by proximal renal tubules in the diseased conditions of tubules. For example, your kidney tubules have diseases, so they'll be excreting some low molecular weight proteins called tubular proteinuria, such as when you have acute or chronic pyelonephritis, heavy metal poisoning, tuberculosis of the kidney, intestinal nephritis, cystinosis, Fanconi syndrome, and rejection of kidney transplant. When you have undergone some kidney transplant and your body has rejected the kidney, you will have tubular proteinuria. So we also have some other types of proteinuria, such as overflow proteinuria, that is from the plasma directly into the urine, such as immunoglobulin light chains of Bence Jones proteins. I'll speak of Bence Jones proteins a little bit later on. Plasma cell, discaries, hemoglobin, all these things, when there is an overflow, it might lead to proteinuria. Then we have hemodynamic proteinuria. It is an alteration of the blood flow through the glomerular, causes increased filtration in the proteins, such as high fevers, hypertension, heavy exercise, congestive cardiac failure, seizures, and exposure to cold. Then we have postrenal proteinuria. Postrenal means after the renal system. This is caused by inflammatory or neoplastic condition in the renal pelvis, ureter, bladder, prostate, or urethra. All these can lead to proteinuria. So we can detect protein in blood using very many components, not only using the dipstick, but we can also do some boiling method. So when we are using the reagent strip method, the reagent strip method uses a specific principle. The principle that the reagent strip method uses is that the reagent area of the protein component, it is coated with the bromophenol blue indicator and buffered to an acid pH which changes color in the presence of proteins. So the bromophenol coated strip is, when it is dipped in the urine, changes in color of the strip indicates the presence of proteins in urine, and it is compared with the color of the chart provided for semi-quantitative grading. Of course, the reagent strip is mainly reactive to albumin. As I said earlier, mainly the reagent strip measures albumin, and sometimes it is false negative if in the presence of Bence Jones proteins, myoglobulins, and hemoglobin. So that one can lead to false positive results. So we can also test for albumin in urine, whereby it is the excretion of up to 30 to 300 milligrams for every 24 hours of albumin in the urine. So that is a condition whereby we refer to as microalbuminuria. And the significance of detecting this albumin is that early detection can sometimes flag or signify renal damage in diabetes mellitus, independent risk factor of cardiovascular disease in diabetes mellitus, and the detection, it is measured the measurement of albumin creatinine ratio in a random urine sample. Then the albumin is also taken very early in the morning or a random urine sample. The measurement of albumin in a 24-hour urine sample, and also we can use the test strip to screen for microalbuminuria. I said I'll speak of something on Bence Jones proteins. So Bence Jones proteins are monoclonal immunoglobulin light chains that are synthesized by the neoplastic plasma cells. The excess production of these light chains occurs in plasma cell dyscarrias, like in multiple myeloma and primary amyloidosis. So because of their low molecular weight and high concentration, they are excreted in the urine. This is a condition whereby we refer to as overflow proteinuria. Since they are very low in molecular weight and they are highly concentrated, then they will overflow in the urine. So unlike other proteins, they have a characteristic behavior of heating. So I want you to be keen here. Bence Jones proteins, when they are heated, they precipitate between 40 to 60 degrees Celsius. They'll form a precipitate between 40 to 60 degrees Celsius, and when heated above 60 degrees Celsius, they will dissolve. When cooled below 60 degrees Celsius, again they precipitate, and when they are cooled again below 40 degrees Celsius, they dissolve. So it means that Bence Jones proteins are very specific. Why? Because they vary between 40 to 60 degrees Celsius is where they precipitate. So when you increase the temperature past 60 degrees Celsius, they will dissolve. Again, when you reduce the temperature to 60 degrees Celsius, they will precipitate. But when you keep reducing the temperature up to below 40 degrees Celsius, they will dissolve. So that is the characteristic behavior of Bence Jones proteins in relation to temperature. Of course, I said they have a low molecular weight, and they are filtered easily in the glomerulus due to low molecular weight. Hence, they must be detected in urine. They have short beta chains in the globulin fraction and are electrophoretically found between beta and alpha globulin bonds. They have all amino acid-like normal proteins except in methionine. So, like I said, the test for Bence Jones proteins, we'll just do a precipitate test at a temperature between 40 to 60 degrees Celsius to determine whether they are Bence Jones proteins. Though this test is not so specific for Bence Jones proteins, and both false positive and false negative results may occur when we are doing this test. And this test has been replaced by protein electrophoresis of concentrated urine samples. So whereby in protein electrophoresis, the movement of charged particles through an electrolyte subjected to an electric field, such as M-band multiple myeloma, there is appearance of precipitate of Bence Jones proteins. So we can use protein electrophoresis in the substitution for the heating precipitate method for determining Bence Jones proteins. Of course, there are other methods used in determination, such as the Harrison's method, Bradshaw's method, electrophoresis, and boiling method. All these are methods that can be used to detect Bence Jones protein. So we also have reducing substances in urine, and reducing substances, generally they are substances that are able of supplying an electron to calcium ions. The two calcium ion, it is blue in color. When reduced to one calcium ion, it will turn to a color called brick red. So of course, reducing substances can be formed in urine, and they can appear in the presence of sugars. Sugars include glucose, fructose, lactose, pentose, galactose, and salicylates. And non-sugars such as drugs, glucuronic acid, creatinine, uric acid. So once we detect that there's maybe reducing sugars in this urine sample, that is when now we will do more complex tests to determine the exact type of reducing sugar present in the urine. So I'll speak of something on glucose. The reason why we test glucose in urine for unsuspected diabetes mellitus, or when we want to follow up an already known diabetic patient, and all of the glucose filtered by the glomeruli is reabsorbed by the proximal renal tubules, and it is returned back into circulation. So but normally very small amounts of glucose is excreted in urine, and these amounts are so little that they cannot be detected by routine urine test. So the recommended amount that should be excreted by urine is less than 500 milligrams in every 24 hours. So the presence of detectable amounts of glucose in urine is a phenomenon that we refer to as glycosuria. So glycosuria results if the filtered glucose load exceeds the capacity of the renal tubule reabsorbed. So some of the causes of glycosuria include glycosuria with hyperglycemia. So glycosuria is the presence of glucose in urine, but hyperglycemia is the presence of high amount of glucose in your bloodstream. So these two things are interrelated, such as during endocrine disease, diabetes mellitus, acromegaly, Cushing syndrome, and hyperthyroidism or pancreatic disease. So all these conditions can lead to glycosuria. So the reagent strip method, it is more specific compared to the Benedict's method or the clean test method. So the reagent strip actually, it is based on glucose oxidase peroxidase reaction, whereby the reagent of the strip is impregnated with enzymes, glucose oxidase and peroxidase, and a chromogen. Chromogen is just a color. So when glucose reacts with oxygen at room air under the enzyme glucose oxidase, it will form glucuronic acid and hydrogen peroxide. So this hydrogen peroxide, it reacts with a chromogen in the presence of the peroxidase to produce oxidized chromogen, which is blue in color, and water. So it is this blue color intensity that is specifically observed for in the urine strip method to detect the amount or the presence of glucose in urine. So you have had that reaction. Glucose reacts with oxygen at room air under the presence of glucose oxidase that is present in the strip to form glucuronic acid. After it has formed glucuronic acid and hydrogen peroxide, the hydrogen peroxide produced then reacts with a chromogen in the presence of peroxidase to form oxidized chromogen that is blue in color and water. So it is this blue color that helps us to determine the amount of glucose in urine. The nature of the chromogen and buffer system differs in different strips. Of course, from strip to strip, depending on the manufacturer, there will be different natures of the chromogen. So the strip is dipped into urine sample, and the color is observed after a specific time and compared with the color chart provided. This test is more sensitive than Benedict's quantitative test and specific only for glucose. Other reducing agents give a negative reaction. So the test is very, very specific for glucose, since there is a presence of a glucose oxidase enzyme there. So there is also a component in the urine strip that we refer to as ketones. So excretion of ketones occur when there is a breakdown of products of fatty acids, and it indicates excessive fatty acid metabolism to produce energy. Normally, the ketone bodies are not detectable in urine of healthy persons. If energy requirements cannot be met by the metabolism of glucose, maybe due to defective carbohydrate metabolism or low carbohydrate intake or increased metabolic needs, the energy is derived from breakdown of fats. So when your body realizes that, hey, you're not giving it enough of glucose due to low dietary take, or maybe you don't take enough carbohydrate, or maybe you have increased your metabolic needs, your body will switch to breaking down fats to produce energy. So the formation of ketone bodies actually happen due to incomplete digestion of this fatty acid called acetoacetic acid. Decreased availability of carbohydrates in the diet can cause ketonuria. Ketonuria actually is the presence of ketones in urine, and this can happen during starvation, persistent vomiting, for example in children, when children are constantly vomiting, a weight reduction program, such as you want to reduce your weight, whereby you severely deny your body from taking in carbohydrate, hence it will switch to breaking down the fats. Increased metabolic needs, such as when children have fever, severe thyrotoxicosis, pregnancy, of course it leads to increased metabolic needs, and protein calorie malnutrition. So there's also urea under chemical analysis of urine. So urea is a white crystalline end product of protein metabolism, and it is eliminated from the bloodstream by the kidney, and it is passed out in the urine. So estimation of urea in the urine is one of the tests that assesses the efficiency of the kidney. The amount of urea excreted in the urine in the renal failure is comparatively very small, and this is because the kidney do not have enough urea concentration power. The conditions such as procreated vomiting and severe prolonged diarrhea, blood urea levels rises and leads to excretion of large amounts of urea in urine. Common methods for estimation is the hypobromite method, whereby urea reacts with sodium hypobromite in alkaline medium to liberate nitrogen, which is collected over water, and it is directly proportional to the amount of urea in urine. I'll show you an equation there about, you can see that equation, whereby the sodium hypobromite reacts with the urea and it liberates nitrogen, and this nitrogen is what is collected, and it is directly proportional to the amount of urea in urine. There's also what we call bile pigments. So bile pigments are usually bilirubin. It is a breakdown product of hemoglobin. It should be undetectable in urine of normal persons. So the presence of bilirubin in urine is called bilirubinuria. So there is conjugated and unconjugated bilirubin. So conjugated bilirubin, it is water soluble and it is filtered by the glomeruli, and therefore it appears in urine, while unconjugated bilirubin is not water soluble. It is bound to albumin and cannot pass through the glomeruli, therefore it does not appear in urine. So the detection is very helpful in differential diagnosis of jaundice. So in acute viral hepatitis, bilirubin appears in urine even after jaundice is clinically apparent. The presence of bilirubin in urine indicates conjugated hyperbilirubinuria or obstructive hepatocellular jaundice. So in hemolytic jaundice, bilirubin should be absent while urobilinogen should be increased. And in hepatocellular jaundice, the bilirubin should be present, but urobilinogen should be increased. And obstructive jaundice, bilirubin is present while urobilinogen is absent. So there is also another component called the urobilinogen. So conjugated bilirubin is excreted into the duodenum through bile, and it is converted by bacterial action to urobilinogen and in the intestine. So the major part is eliminated into the feces. A proportion of urobilinogen is absorbed into the blood, which undergoes recycling, and a small amount, which is not taken up by the liver, is excreted in urine. So you can see that urobilinogen, it is excreted in the feces, but there is a small amount that is taken up by the blood for recycling, and there is also another small amount that it's not taken up by the liver, it is excreted in the urine. So urobilinogen is colorless. Upon oxidation, it is converted to urobilin, which is orange-yellow in color. So normally, about 0.5 to 4 milligrams of urobilinogen is excreted in urine in every 24 hours. But urinary excretion of urobilinogen shows diurnal variation with high levels in the afternoon. A 24-hour post-meal sample is usually preferred. So there are some causes of increased bilirubin in the system, such as hemolysis, increased urobilinogen in urine without bilirubin. During hemolysis, there is hemorrhage in tissue, and the causes of reduced urobilinogen in urine include during obstructive jaundice, reduction of intestinal bacterial flora. For example, you take antibiotics and it clears your intestinal normal flora, and this is common in neonates following antibiotic treatment. So we'll also speak of blood. The presence of abnormal number of intact red blood cells in urine is called hematuria, and some causes of hematuria include diseases of the urinary tract like glomerular disease and non-glomerular diseases such as tumor infection, tuberculosis, pyelonephritis, hydronephrosis, polycystic kidney disease, trauma. All those diseases can lead to blood in urine. Also the test for nitrites. So nitrites are not present in normal urine, and ingested nitrites are converted to nitrate and excreted in the urine. For example, in the place of gram-negative bacteria such as E. coli, Salmonella, Proteus, Klebsiella, these bacteria can actually lead to the presence of nitrites in urine. Nitrites are then detected in urine by reagent strip method. Leukocyte esterase test that is released in the urine from granules of the leukocytes. Then the test is positive in pyuria. If the test is positive, urine culture should be done. The test is not sensitive to leukocytes. So there is microscopic examination of urine. The microscopic examination of urine sediments can provide important information and also evidence of some renal disease. It indicates a type and a state of activity of the renal lesions or disease. A normal urine microscopy contains a few epithelial cells, occasionally RBCs, and few crystals. So urine consists of various microscopic insoluble solid elements in suspension. These elements are classified and organized or unorganized. Organized substances include RBCs, white blood cells, and epithelial cells. Also organized substances include things like cast, hyaline or granular casts, bacteria such as Pseudomonas and Proteus and parasites, spermatozoa, significant in male, yeast cells such as Candida albicans, flagellates such as Trichomonas vaginalis, which is also called the dancing ballerina girl, which causes vaginitis or urethritis, and unrecognized substances are crystalline and amorphous materials which are suspended in urine, and on a standing they settle down and sediment at the bottom of the container. Their presence depends on the urine pH. Mostly crystals that appear acidic in urine dissolve in alkaline urine and vice versa. Calcium oxalates are found in both acidic and alkaline urine. Spermatozoa as a type of cell that is found in urine. We have different crystals in urine, and crystals are refractile structures with a definitive geometric shape due to orderly 3 to 5 dimensional arrangement. Some of the crystals in urine are normal crystal, calcium oxalate, triple phosphate, uric acid, amorphous phosphate, amorphous urate, ammonium urate, abnormal crystals, cysteine, cholesterol, bilirubin, tyrosine, sulfonamide, and leucine. So we also have casts, and there are two types. There is non-cellular, which is the higher line, granular, waxy, and fatty. Then we have cellular casts such as RBCs, white blood cells, renal tubular epithelial cells. Different organisms that can be found in urine, such as bacteria and yeast. We also find Trichomonas vaginalis, and we can also find eggs of Schistosoma hematobium in urine. The end of our video, and thanks for staying with me. And if you haven't subscribed to my YouTube channel, please take the next 5 seconds to just hit that subscribe button. 5, 4, 3, 2, 1. Thank you for subscribing. Bye.